much. The next speaker is kind of the queen of CRT, Ashita Tolwani from UAB. I'll just say that she has caused, I'll give her a little bit of cause for embarrassment here, but she has caused ASN to change their rules because last year she won both the Burton Rose Award for Teaching Excellence as well as the Robert Narons Award. And so now they've changed the rules so nobody can win 2 awards in 1 year because she's the only person to have ever done that. So that tells you how great of a speaker she is. And she's going to talk to us about challenges in timing of RRT initiation in AKI. Welcome, Ashita, and thank you.
Thank you so much for that very kind introduction. I appreciate it very, very, very much. I don't think I deserve those awards. I'm still trying to live up to those awards, so I'm still improving. But I'm so excited to be here with all of you. I'm so honored to be able to be here virtually, and I look forward to hopefully being with you physically next time if I'm invited back. So I've been tasked with talking about challenges and timing of renal replacement therapy initiation in acute kidney injury. So this is my disclosure slide. So essentially, these are my objectives. And essentially what I'm going to do is review the timing based on the recent literature that we have. So I would also like to say that some of my illustrations were from Dr. Michael Connor, and I appreciate the use of his slides. He made a very similar presentation at CRT Academy last year. So let's start. When you look at definitions for timing, basically we like to think of conventional or late versus early initiation. So conventional or late, we're all familiar what that means. That's for the life-threatening indications such as hyperkalemia, severe acidemia, life-threatening volume overload, uremia, essentially when there is no more way for medical management to manage these problems. If you look at early or preemptive, so in observational studies, the cut points of what defined early or preemptive varied and could be anywhere from a BUN to urine output to even admission day to the ICU. But what we're going to focus on is the randomized trials today. And if you look at the early or what's considered to be early on randomized trials that we'll talk about today, this is based on a staging criteria, the KDIGO staging criteria, which we're going to talk about. And of course, the goal for this is to prevent the development of life-threatening complications of AKI, is perhaps if we start earlier, we can improve outcomes. So let's look at the pros and cons of early versus late initiation. So we know the theoretical advantages: uremic metabolic control, improved fluid management and prevention of volume overload, which we know specifically in critically ill patients is a big issue. Perhaps by achieving earlier fluid management, earlier acid-base homeostasis, we can improve outcomes. We also know in the ICU setting, many patients have other organs that are not functional or congested, whether it be heart failure, hepatic congestion, etc. So perhaps by starting earlier, we can improve non-renal organ function. And again, the whole advantage of what we're trying to do this for is improve clinical outcomes, whether it be renal recovery or survival. But we all know there are plenty of theoretical drawbacks of why we tend to wait to the conventional indications. And this includes infectious mechanical complications of the catheter that we're all aware of, biocompatibility of the hemofilter and reactions that can occur because of that. Depending on what anticoagulant you use, you can have bleeding complications, or if you use citrate anticoagulation for CRT, metabolic complications related to citrate. We know that dialysis can cause hypotension, and this may decrease renal recovery. And depending on the dialytic modality you use, you can have extensive loss of nutrients or drugs, and this makes it very difficult in some modalities of prescribing drugs and nutrients. Dialysis, of course, is more costly. And the big drawback is we don't want to unnecessarily give this therapy that could have these potential negative side effects in someone who's going to spontaneously renal recovery. So this has been the issue for years and years and years. But luckily, despite these advantages, disadvantages, pros and cons, there have been recently landmark studies that have helped us to decide whether early initiation, well, we'll see if it helps us decide this, is better. And what I'm going to focus on, this is a timeline currently of randomized trials, not observational studies done in this area. And basically what I'm going to focus on are the ones from 2016 onwards, which are the ELAIN trial, the AKIKI trial, the IDEAL-ICU, the STARRT AKI trial, and now the AKIKI 2 trial. So let's start with the AKIKI trial. This was a trial, a multi-center trial in France that was published in 2016. And again, all these trials are focusing on ICU patients with the clinical diagnosis of ATN. So in this trial, patients were eligible if they achieved KDIGO stage 3 AKI, and they had to have either mechanical ventilation or pressors. And the principal hypothesis was that delayed renal replacement therapy initiation reduces absolute 60-day mortality by 15%. So once patients were eligible, they were randomized either to the early renal replacement therapy arm, which was initiating renal replacement therapy less than 6 hours of meeting this eligibility criteria, versus the delayed renal replacement therapy arm, which is the standard conventional indications we're all familiar with. They enrolled 620 patients. And interestingly enough, these were the results, but in the early strategy, 98% commenced renal replacement therapy at a median 2 hours after post-randomization. And the delayed strategy, only 51% commenced renal replacement therapy, and it was a median of 57 hours post-randomization. And the reason it was only 51% because the others either died or recovered kidney function before the time of initiation. And as you can see by this Kaplan-Meier curve, there is no difference in mortality at 60 days. There was also no difference in dialysis dependence at 60 days. However, in the early strategy, there was more complications related to the central venous access and more hypophosphatemia. So one study. As you're all aware, at the same time, another study was published within a week of that study called the ELAIN trial, which again was an initiation trial for renal replacement therapy timing, but it was a single study this time in Germany. The difference, again, we have ICU patients with a clinical diagnosis of AKI. The difference is that in this trial, patients were eligible at an earlier stage of AKI, stage 2. So doubling of creatinine compared to a tripling of creatinine in the previous study. Patients also had to have a plasma NGAL level greater than 150, and an additional factor, which was either severe sepsis, use of catecholamines, refractory fluid overload, or a SOFA score greater than equal to 2. Their primary hypothesis, unlike the previous study, was that earlier renal replacement therapy reduces 90-day all-cause mortality. So the previous one was hypothesizing delayed reduced. This was earlier reduced. So when patients were eligible, the early arm was initiation within less than 8 hours of meeting these criteria. And the delayed arm was either less than 12 hours after achieving stage 3 AKI or emergent indications, as we know. And they enrolled 231 patients. So in the early strategy, 100% started renal replacement therapy. It was a median of 6 hours from time of eligibility. And the delayed strategy, impressively, 91% started, and it was a median of 25 hours from eligibility. So if you look at the timing from eligibility based on KDIGO 2, these are the mean results. So there was a separation between the two. So what did the studies show? Well, unlike the previous study, this trial showed that patients who were started earlier had a significant improvement in survival as compared to the delayed arm. And you can see the p-value was 0.03. If you look at some of the other outcomes, I already talked about the primary outcome mortality, which again shown here is that earlier is better statistically by this study. But these patients who were started on the earlier arm also had decreased duration of renal replacement therapy, decreased hospital stay, and decreased duration of mechanical ventilation. So here we have two trials with two different outcomes. What do? Well, before I talk about that, let's go on and look at the other trials and put it all together. So then we had the IDEAL-ICU study. This was another multi-center study done in France. The only difference is that now these patients, of course, all adult ICU patients with a clinical diagnosis of ATN, but the difference is now that they have to have septic shock. Like the AKIKI trial, eligibility also included a KDIGO stage of 3 AKI. And their principal hypothesis was that early this time reduces 90-day all-cause mortality by 10%. So in the early arm, patients were randomized to the early arm. In the early arm was renal replacement therapy less than 12 hours. And the delayed arm was either 48 hours of the AKI persisted or the conventional indications we know of. And 488 patients were enrolled. So in the early strategy, 97% commenced renal replacement therapy. It was a median of 8 hours after randomization. And the delayed strategy, very similar to the AKIKI, there was a smaller number that actually received renal replacement therapy, 62%. And this was, they started at 52 hours after post-randomization. And very similar to the AKIKI trial, the reason for the decreased number is that a significant amount did not receive renal replacement therapy due to spontaneous recovery, or they died before initiation. And what do the outcomes show in this study? Death at 90 days, no difference. There's also no difference in secondary outcomes. Here's the Kaplan-Meier curve showing that same outcome. So one thing I must say about this study is that it was actually underpowered, because after the second interim analysis, they deemed that completion of enrollment was unlikely to change the results, and so was stopped for futility. So that's really interesting. So 3 trials, 1 positive, 2 negative. Again, what does that mean? All right, let's talk about now the 2 most recent trials published within the last several years. So let's talk specifically now about the STARRT AKI trial, or STARRT AKI trial, which this trial was the largest trial to date. It was a multi-international trial of 168 clinical sites. We were fortunate enough to be able to participate, 15 countries. And again, an ICU study aimed at timing. They were aiming for a 90% power to detect a 15% relative difference between the groups based on enrollment of 2,866 patients. And they're assuming 40% mortality in the standard arm based on the literature. So they did increase enrollment to 3,000 to account for loss to follow-up. And this study took place over 4 years, and they eventually randomized 3,019 patients out of 11,852 patients. How this study differed from the other studies is that when the patients were eligible, you had to have agreement among the intensivist and the nephrologist and equipoise that they were okay with the study first. So it was a little bit more practical oriented in the previous studies. So like the ELAIN trial, patients were eligible at KDIGO stage 2. The accelerated arm was starting renal replacement therapy less than 12 hours of eligibility. The standard arm was, again, standard conventional indications were all available. 97% commenced an accelerated arm at a median of 6 hours after randomization, while similar to the AKIKI and also the IDEAL-ICU trial, 62% commenced 31 hours after randomization, and it was decreased due to the same things, either death before starting renal replacement therapy or recovery. And again, we said 3,019 patients were randomized. What did this show? No difference. There is no significant difference, not only in overall mortality or survival, but also in any pre-specified groups, whether it was surgical patients, septic patients, etc. They did see, however, there were more adverse events in the accelerated arm, particularly consistent with hypotension and hypophosphatemia. If you look at some of the secondary outcomes, there was significant difference in the dependence on renal replacement therapy at day 90 after randomization. in the sense that the accelerated arm had increased dependence on renal replacement therapy. And the patients in the accelerated arm also had shorter ICU stay. There was no significant difference in the major adverse kidney event, which was a combination of death and dependence on renal replacement therapy or sustained reduction in kidney function. No difference in renal replacement therapy free days, mechanical ventilation, vasoactive therapy, et cetera, et cetera. So how do we put this together before I talk about the AKIKI 2? We now have 4 trials with 3 showing a negative outcome and 1 showing positive. How do we interpret this? Well, there are differences within the trials themselves. The one that was positive, the ELAIN trial, of course, was a single center study, and I've outlined the positive trial in yellow. And if you can see some of the differences, the populations were slightly different. The ELAIN trial, 95% were surgical, of which a majority were cardiovascular patients, while in the other 3 studies, they were either medical or a mixed surgical group. We can also see there was differences in what constituted early initiation, where the STARRT study and the ELAIN trial, eligibility was at an earlier stage, stage 2. Other differences, modality of renal replacement therapy. So the ELAIN trial was the only trial where all patients received initially RRT, while the other trials was a combination of different modalities. So you can see, going back to this, those were the main differences. The enrollment SOFA score was a little bit higher in the ELAIN trial, and then these other outcome points I already mentioned. So what does that mean? How do we interpret this data? So before we talk about final interpretation of that data, let's talk quickly about the AKIKI 2 trial, and then I'll give you my interpretation of how we look at all that data. So since all those other trials, except ELAIN trial, showed that later dialysis or conventional dialysis for conventional indications did not seem to be worse, maybe we can delay the dialysis even further. So what that meant is in this trial, they took adult ICU patients who are mechanical ventilation oppressors, already at stage 3, already with oliguria more than 72 hours, and a BUN greater than 112 milligrams per deciliter, and then randomized the patient. A delayed strategy was renal replacement therapy less than 12 hours of meeting these criteria, while more delayed was mandatory indication or a BUN of 140. Now, why I separated this trial from the previous combination of studies that I made in that table was because this primary outcome for this trial was a number of renal replacement therapy free days between randomization and day 28, and mortality or survival was a secondary outcome. They enrolled 278 patients. In the early strategy, conventional, or I should say delayed versus more delayed, 98% commenced at 3 hours after randomization, a median, and the delayed, it was more like 33 hours. Interesting enough, 79% patients actually did start. If you look at all their primary and secondary outcomes, there was no difference. So there was no difference in renal replacement therapy free days, no difference in mortality. But if you looked at the multivariable analysis, the risk factors associated with 60-day mortality was actually having a more delayed strategy. Also the severity of illness scoring and the presence of mechanical ventilation. So now, how do we put this together? Well, the 3 largest randomized controlled trials, and I'm not including AKIKI 2 since it was primary outcome was a little bit different, show no benefit in terms of mortality from earlier initiation of renal replacement therapy at stage 2 or 3 AKI. But it's interesting to see that in most of those trials, 30 to 40% of the standard arms never needed renal replacement therapy. Possibly there was a benefit from early renal replacement therapy in surgical patients, but I would argue that in these 3 trials, except for the STARRT study trial, or in these all 4 trials, I should say, that they were actually underpowered. And it's been noted in the literature in the ELAIN trial, if the fragility index was very, very low, meaning that essentially if a few patients moved to the other arm by chance, the results would have been non-significant. So what we did learn also is that early renal placement therapy may be associated with adverse outcomes. In the AKIKI 1 trial, there was increased risk of infections. And in the STARRT trial, as I pointed out, there's increased risk of renal replacement therapy dependence. So what I have learned from these trials is that, first of all, my biggest issue is that, serum creatinine and urine output definitions may really not be ideal for determining need for renal replacement therapy or AKI severity, and certainly not how I make my decisions on a daily basis. So I think rather than we focus on the staging criteria and look at these trials, although they provided us a lot of good information, I think when we're looking at early or late renal replacement therapy initiation, it's really more appropriate to look at when initiation is most appropriate. It's really whom, more precision-based medicine, whom initiation is most appropriate rather than when at the timing. And I'm going to clarify what I mean by that in the next few slides. So before I give you my whole overall sense of these trials, I do want to point out there are other ways to look at timing that may be a little bit more beneficial and actually target it to who rather than when. And this is one of them. So this is based on the furosemide stress test, which you'll get a talk, I think, in a few more lectures after me about. And so this was a pilot study or feasibility, and patients who had the clinical diagnosis of ATN were randomized to initiation based on the results of the furosemide stress trial. So in these patients who were admitted, they performed the furosemide stress test, and those who were responsive were excluded from the study, meaning that they had a urine output greater than 200 cc's within 2 hours. Those who did not respond, they took those patients and randomized it. So early randomization was within several hours of meeting the diagnosis or having the furosemide stress test be negative, and late or was by conventional indications. So interesting enough, when you look at the furosemide stress test to determine risk for progressive AKI, you can see that the baseline characteristics for those who failed or passed were the same, as well as the serum creatinine, there was no difference. Of those who failed the test, the ones who were enrolled in the study, 87% eventually needed renal replacement therapy. Those who passed, only 6 out of 44. So it's actually a very decent test, and you'll hear more about that in a future lecture. Now, since this was a pilot study, it showed no difference. And I'm waiting to see if this group has a larger randomized trial, because I do think that this may be a better way to look at whether the need of renal replacement therapy timing than some of the other studies we talked about. But more importantly, to finish up my talk, I would like to discuss how we actually look at patients on a daily basis and why it's so difficult to capture in these studies. So when I come to the ICU, I basically look at trajectories, not just a single staging. And I look at the other things that are associated with it, electrolyte derangements, the acid-base status, what other complications, and we have to predict again, how is that trajectory going to change over the next 12 to 24 hours? And what's the severity of AKI? Also, other things that are important is what's the inciting event leading to AKI? Is that inciting event still present or likely to improve? Do we have other organs that are compromised by the AKI, such as heart failure, hepatic congestion, etc.? What is the degree of fluid overload? What are their other comorbidities? And again, trajectory. We also have to counteract this between the potential risks of renal replacement therapy. Are they severely coagulopathic? Are they a difficult access? What are the risk factors or, risks of hypotension? How do we manage clearance of nutrients and drugs? And then there's serious other factors, which of course became even more prominent in COVID area: availability of machines, availability of staff. what we think is whether futility, prognosis, and family wishes. So all of these things take into account our decision, or taken into account for our decision. So what I like is thinking about it this way of initiation. And this is how I do it on a daily basis in the ICU. The key principle, and this was based on an AKIKI conference, consensus conference, is that the kidneys have a limited capacity, and the degree and impact of fluid and metabolic derangement vary between patients. And what you're trying to find out is this perfect place between harm and benefit. And eventually it boils down to the individual, whom and not when, because early renal replacement therapy for one patient may be too late for a different patient. And that is really the bottom line for me in terms of timing of initiation. So this AKIKI consensus conference that I was fortunate to be part of in 2016 actually came out with a statement that renal replacement therapy should be considered when the metabolic and fluid demands exceed this total kidney capacity and not based on a renal function or AKI stage. And so when you initiate it, it should be based on the ability of kidney to meet the demands. And so it's a balancing issue. And what are the factors that go into this? Everything that I've already said. We take into account the degree of fluid overload, the solute load, the severity of illness, other comorbidities. And we try to look at how this is going to be impacted by initiation renal replacement therapy. So an example, what they listed is someone may have a high demand with normal capacity, but you would need to initiate renal replacement therapy. So this may be someone who has high catabolic state in patients with normal renal function, or someone who's extremely volume overloaded, and despite having a relatively preserved renal function, needs extra volume removal, not responsive diuretics, which some of our ECMO patients have. Demand could be high with a low capacity. This is an example of high catabolic state in patient who already has AKI. You could have a normal demand, but the kidney capacity extremely low. Or you can have the demand is low and the capacity is low, and this may be a malnutrition patient, and then you have to consider initiation based on those factors. So I'm just giving you examples of how to look at it. And there are groups who are trying to develop this demand capacity ratio to further help us decide when's best initiation. To stay tuned, because I've been involved in some of those projects and I'm excited about it. So in summary, at my ending time, I think that we've got a lot of valuable information regarding studies of timing. We know we can do these studies, and further information will come out of the STARRT trial, et cetera, to help guide us. But I do think that we need to use we do use other diagnostics than a serum creatinine urine output. And they probably don't give adequate prognostics. And again, it's very hard to generalize this to all patients. You really need to think of the individual patient, whom and not when. And so that's essentially what needs to be done. And with that, I'd like to conclude my talk and see if there's any questions to help anybody with. Thank you very much.